we've all finished the exam and done very, very well. And this first series of lectures will be on the respiratory system. The first part, we'll just talk about the normal structure and function of the respiratory system. We'll talk about infection patterns depending on where it's located within the respiratory system, which means obviously we get to talk about the inflammatory process and innate immunity again, which I enjoy. And then we'll talk about disorders of the obstructive versus restrictive disorders. So starting with the normal respiratory process and the respiratory system itself, there are three main functions, which include ventilation, which is moving the air in and out, perfusion, which for the respiratory system, there's really a dual blood supply. The first is what we see at the alveoli where gas exchange takes place. That's the blood leaving the pulmonary artery in order to get oxygen and then coming back through the pulmonary veins into the heart. That's just for gas exchange, and that's considered the pulmonary circulation. There is, however, the bronchial circulation, which is what supports the airways and the lung parenchyma, the lung tissue itself, for its oxygen needs. And that additionally helps to warm and humidify the air, so it has a dual purpose. And then, of course, the whole reason for the system is to get down to the bottom here in order to diffuse gases, in order to get oxygen into the bloodstream and to get carbon dioxide out and into the environment. It's also very important that we make a distinction between the two types of respiratory tissue. Sometimes as nurses, we just talk about lungs and disorders of the lungs, and we sort of blur the lines between issues with the conducting section of the lungs and issues with the actual diffusion or the area where the gas exchange takes place. So you can't just use lung broadly. You have to say this is an issue with the conducting airways, or this is an issue with the respiratory tissues, the lung lobules. It's very different. So looking at the types of tissue, the conducting airways are the air, comes in through the oral or nasal pharynx down past the epiglottis and the larynx. Nasal passages, mouth, oral pharynx, larynx, which has the folds for talking, vestibular and vocal cords, the trachea, bronchi, bronchioles getting smaller and smaller as we go down the tubes. This conduction system, these are conducting airways. The sole purpose is to get the air down to the respiratory lobule where the gas exchange takes place. This has, the connective tissue covering. There is a layer of smooth muscle which is responsive to the autonomic nervous system, which will cause constriction of the tubes or dilation of the tubes, depending on what's needed. It's supposed to be lined with healthy squamous epithelial cells that have villi on them, and goblet cells, which help to secrete mucus to sort of coat the area. And that is what we would call innate immunity. That's the first layer of innate immunity, is creating the barriers to infection, because we have cells that are closely adhesed together, and mucus that would help entrap foreign material, bacteria, viruses, and then the ability with our smooth muscle as well to help get stuff out that doesn't belong with our cough. This blood supply to this area will also help to warm and humidify the air. Keeping this tissue healthy is very important in terms of preventing infection. And so we talked about before in the first classes that we had that chronic irritation, such as cigarette smoking, can change this mucociliary blanket, as we like to call it, or change the quality of this tissue through that metaplasia. The chronic irritation will change these cells from squamous to cuboidal cells and begin the process of cellular change. So, and then there's a slide picture at slide number 7 that shows a electron microscope view of the conducting airways with the cilia, the submucosal connective tissue, and that secreting mucus secreting glands that help to protect the airways. Then, as we get lower, here's the bottom of the conducting systems. Remember, it's a series of tubes that get smaller and smaller and smaller till we get to the very end, which is the lung lobule. That's where the gas exchange takes place. The picture you see there is a bunch of alveoli, as well as the lung parenchyma, which is the tissue that surrounds conducting airways in the lung lobules. That's really just connective tissue, fibrous tissue, stromal tissue, supportive and giving the lungs their structure. So the lung lobule consists of the terminal part of this bronchus, which is the alveoli, and the capillary where gas exchange can take place. So inside the alveoli, which is pictured here, there are different types of squamous epithelial cells. There are type 1 squamous epithelial cells, which give the structure, the thin layer, and type 2, which are actually cuboidal cells, so slightly different, but still epithelial cells. Their main job is to secrete the lipoprotein surfactant to protect this alveoli. So, we get one of the main things that lipoprotein surfactant helps is to prevent this alveoli from completely collapsing, because then we would have to generate a lot of pressure in order to open the alveoli with each breath. So we want, at the end of expiration, we don't want all these little alveoli to collapse and close, because then it would take a lot of energy for us to open them up again and overcome the surface tension that's created. So the surfactant helps prevent the alveoli from collapsing. Additionally, there are other brush cells or alveoli cells that are attached to macrophages. So if any sort of foreign material, bacteria, virus makes its way down this passage, wasn't taken care of above, then it could potentially be engulfed by the macrophage and taken out of the system before it can cause an infection, hopefully. So the first thing that we need to talk about is ventilation, is how we're going to get the air from the environment into the lungs in order for gas exchange to take place. And then when that occurs, how do we get that air that was there back out? And in order to understand that, we have to keep in mind that everything in the body moves by pressure gradients, from areas of high concentration to areas of low concentration, high volume, low volume, high concentration, low concentration, high pressure, low pressure. That's how the body likes to move. Down concentration gradients, because then no energy is expended. It's a normal force of movement. So if we're trying to figure out how we're going to get air into the lung cavity so that gas exchange can take place, it does occur down concentration gradients. To understand that, we have to understand what makes up air pressure or barometric pressure, or pressure in the environment, and respiratory, or pressure in the chest cavity itself. And how can we create differences in those pressures in order to drive movement down pressure gradients? So the air pressure, or the barometric pressure, equals the total sum of all partial pressures. So that sounds complicated, but it's really not. So air itself is made up of different types of molecules like oxygen, carbon dioxide, nitrogen, whatever other pollutants are in the air itself. Each of those exerts its own partial pressure. So if I have a sum total of air with its own pressure, a percentage of that is because of oxygen, a percentage of that is because of nitrogen, a percentage of that is from carbon dioxide. The total air pressure is me adding up all those partial pressures of oxygen, nitrogen, and what else is in there. That's how I get the total air pressure. The total respiratory pressure is made up of the structures of the respiratory system, like the pleura, the lung parenchyma, the conducting tubes, as well as the air, the pressure of the different types of gases that are in the respiratory system. That makes up the pressure inside there. So what the respiratory system does, which is it's really cool actually, is takes advantage of the fact that pressure changes depending on the size of the container it's in. So here are two, it might be hard to see because I didn't make my particles very big, so I'll make them bigger. Here are two containers. They both contain the same amount of particles. We'll say that what we see here, it defines the pressure of oxygen. It's a partial pressure of oxygen. There's an increased pressure in a smaller cavity. So this has less pressure, less concentration, because it's in a bigger cavity. The smaller cavity, increased concentration, increased pressure. So the way we move air in and out of the body has to do with changing the size of the container of the chest cavity. If I can change the size of this container, then I can change the pressure measurement, and in that way I can help drive air in and out. So let's explain that. That's the role of the respiratory muscles. Okay, so I want to get air into the lungs. Then if the pressure inside the chest cavity and the pressure in the atmosphere are equal, I won't be able to get air to move. And that's how it would be normally. So somehow, so this would be in between, the pressure outside and the pressure inside is the same. So if I want to draw breath in or bring air in or have air move down its concentration gradient, then I have to create a gradient. I have to decrease the pressure in the chest cavity. And the way I can do that is increase the size of the chest cavity. And the way that's done is to contract the diaphragm. When I contract the diaphragm, it moves downwards and increases the size of the chest cavity. Then there's less pressure in this compartment than there is outside, and air will move down its concentration gradient until again they equal each other. Here's 15 millimeters of mercury and 15 millimeters of mercury. They're equal to each other. The epiglottis is closed. There's no air movement. That's between inspiration and expiration. Normally, expiration is a passive process. So when the diaphragm relaxes, it moves back up, making this container smaller, which increases the pressure in comparison to the outside, forces the epiglottis open and forces air out. And then it repeats itself. So normally the respiratory muscles are driven by, the autonomic nervous system. I'm not even thinking about it. The diaphragm contracts for inspiration, passively relaxes for expiration. Not a lot of work going on here. This is all, it's not like an active movement. There's no, this should not cause a lot of effort for me. If for some reason I was sick, lots of pathology we're going to discuss, Or even if I was working out and increasing the oxygen demands of my body, meaning I'm going to have to bring more air in and get that air out, then I'm going to use more of the muscles of the respiratory area in order to change the sizes of the containers sort of more aggressively. So if I'm running or doing some kind of activity, then I will start to use some of the other muscles of this area, both sets of intercostal muscles, the muscles between my rib cage to pull the rib cage up, and my sternocleidomastoid muscles so I can pull the rib cage up even further, so I can make this cavity larger, so I can push more air into my lungs. And then I can't just passively relax the diaphragm. I use all these muscles. There's more activity. So the diaphragm goes up, and then there's the activity of the opposing intercostals to help bring the chest cavity down. So I have a built-in mechanism in order to increase and decrease the size of these cavities depending on my need, whether I be ill or I have an increased activity needs. So last unit we talked about blood flow, because blood is going through tubes or pipes. This time we're talking about airflow, how air flows between the conducting tubes to get to its destination, which is the lung lobule for gas exchange. So some of the same things that we talked about when we talked about blood flow is, we had to create a pressure gradient, which we were just talked about, but there's certain things that favor flow and certain things that don't favor flow. One is we want the flow to be laminar, meaning in the straight lines without turbulence. So if there's anything that's in the airway, like a mucus plug or a tumor or something that's going to cause turbulent flow, and we're going to have less flow down to where we need it. So we want straight laminar flow of air. We know that one of the biggest, the same thing that we talked about with flow of blood vessels also hangs true for the conduction of air through the conducting airways. We want the pressure difference, the pressure gradient, which we got from the respiratory muscles. That helps increase flow. They have a direct relationship, but there's an indirect relationship with the radius of the tube. If the radius is decreased, there's an indirect relationship with resistance. And resistance is determined by radius. So if resistance increases, then flow decreases. And the biggest impact on resistance is the radius. So if the radius or diameter of the lung tube decreases, then it's harder to get air down to the lung lobule. So it's resistance. If resistance increases, flow decreases because they have an inverse relationship. And the biggest impact on resistance is the radius. So if the person had some sort of obstructive disorder that changed the radius of the lung tube, like chronic asthma or COPD, or if the person had an infection with inflammation changing the radius of the lung tube, that would decrease the flow down to the lung lobule for gas exchange. Another issue that occurs with the lungs is something called airway compression. So if we're changing the pressure to too high of an extent, it's possible to compress this airway. So say we're trying to force air out. So we had a big inspiration. We engaged the sternocleidomastoid muscles, the intercostal muscles, the diaphragm is down, and now we have to blow all that out. So we have to generate a lot of pressure. And in our need to do that, and we make the cavity smaller, we could increase the pressure inside the chest too hard. So much so that we actually compress the airway and we don't allow all the air to get out. This compression can lead to air trapping. And this is the problem that we see when we talk about obstructive lung disorders like asthma during severe asthma attacks or in COP emphysema all the time. It's because the pressure inside the chest cavity is high. When we try to breathe out, sometimes the airways get compressed before all the air can get out, and we end up with air trapped inside, which will influence the next time we try to take a deep breath. So the main concepts here, what determines airflow is the pressure gradient, which was the respiratory muscles, is that there's no irregularity to this conducting pathway so that there's no turbulence because that slows flow down. We want the radius to be correct because radius impacts resistance, and if resistance goes up, then airflow goes down. And we don't want the pressure inside the chest, especially on expiration, to be too high that it actually compresses the airways because then we get air trapped inside. So the whole reason we have the pressure changes to get the air in, the tubes hopefully are open and clear and not compressed so that we can get air down to the lobule where gas exchange takes place. So we want the gases to diffuse. We want oxygen from the environment to leave the alveoli and go into the capillary. And we want carbon dioxide that's left over from metabolism to leave the capillary and go into the alveoli so they can go out into the environment. So we need to be able to diffuse these gases across this membrane between the alveoli, the little basement membrane separation between them, and the capillary endothelial cells. So how do we know, or what affects the diffusion of these gases across? One, so this is called, this equation, and this is for you on slide 17, this is called Fick's law of diffusion. How can we predict, or how do we know what affects the diffusion of gases across the membrane? And these are what does this. So K is a constant. You don't have to worry about that in terms of pathophysiology for our class. It is the diffusion constant, like what I will predict the amount of oxygen that would pass through based on its solubility. So there's nothing, that's a constant calculation, it's just there. But it does affect things, obviously. A is for surface area. So how many alveoli are open and ready and able to be used? How can I get there? So if the alveoli are collapsed because of atelectasis, or maybe the baby was born prematurely, so there's not enough surfactant, then there's going to be less surface area for diffusion of gases if I lose some of my overall volume of alveoli. If there's a huge tumor compressing that area, then I've lost some of the surface area of the alveoli for gas exchange. There needs to be pressure difference, so I had to have been able to get oxygen here, creating a pressure difference, the pressure of oxygen difference, or the concentration difference between oxygen in this alveoli and oxygen in this vessel in order for it to diffuse down its concentration gradient. There has to be a gradient. So surface area and concentration gradient both have what's called a direct relationship with diffusion, meaning the greater the surface area, the greater the concentration gradient, the more gases will diffuse. This part here is thickness. How thick is this membrane? Which can be affected by different diseases, but could certainly be affected by inflammation. If I make the membrane thicker between the alveoli and this capillary, then it's going to take longer and be harder to diffuse gases across this membrane. So membrane thickness has an indirect relationship with diffusion, meaning if the membrane becomes thicker, then diffusion goes down. And this will help us understand, using physics, why if somebody has certain respiratory pathology like infections or cancer, etc., it will directly or indirectly affect the ability to diffuse gases in the lung lobule. And that is some of the basic functions of the respiratory system, how we get air to move in and out, how we get to diffuse gases. And then the next group of slides will be regarding infections of this system in particular.